Let's now discuss the electrophysiology of the eye. We said in the retinal lecture that when we perceive the light as a response of electrical stimulation. So when our eyes are subjected to light, this light will induce a photochemical reaction, in which there is a change of the photo energy or the light energy into a chemical response in the retina that will result in generation of electrical current that start from or initiated from the photoreceptors until it reaches the different retinal layers and will pass through the optic nerve and visual pathway. So we can record this electrical activity, as since it is present all the time. They are present even during the dark. As we said, there is what's called dark current, and it present and the light. So the light only just augment or change the amount of electrical activity. But if you have an example, or if you have a question in the exam telling you, well, there is no electrical activity in the dark, so the answer is wrong. There is some electrical activity in the dark, as we said before, but it is changed with light. So either it is hyperpolarization or depolarization. There is a change in the response of the light. So the response in the light become just more rapid and more well-defined. As during dark or during light, there is a what's called membrane potential. So the photoreceptors have some charges, as we said before, like the sodium. When it enters the cell, the sodium influx causing some electrical changes in the cell. So even in the rest, there is called a resting potential or electric receptor potential. This is present all the time. And then it is conducted to the retinal layer as a direct flow of electrical current, as except for the ganglion cells, as we said that the ganglion cell will respond to electrical stimulation by a full action potential. So the basis of different photoreceptor or different electrophysiological devices, that it measures the response from different retinal and even extraretinal layers. So we'll start first by discussing the electroretinogram. So as the ECG will record the electrical discharge from the heart, the electroretinogram will record the electrical discharge coming from the retina. So it is a recording device that will respond to electric discharge from the retina. After stimulation by flashlight, which will be this response, or this electric response is due to the change of the ionic movement across the different layers of the retina. So as we stimulate the retina by light, this will cause some electrical current initiated at the photoreceptors that will be passing through the different layers of the retina, passing through the bipolar and then the amacrine cells and ganglion cells until it reaches the optic nerve. So the electric or the ERG is a device that will record this electrical activity. So how can it is done? The patient put his head in a device or in a bowl. This bowl is called the Ganz field or the full field bowl. So then the patient, we put a contact lens. This contact lens is attached to an electrode. This electrode will record the electrical activity between the cornea and the patient's retina. Then the electrical impulse will pass through the device and will be amplified. So if we only see the electrical impulses from the retina, it will be very weak. So the device or this device will increase, or they will amplify the impulses coming from the retina in order to see them as either written or at XY plotter. So what are we need for what is the most important thing in the electrophysiology is to know what is the source of each wave and when do we use each device, on when we need to order ERG or EOG or VEP. So for the ERG, the main waves here are called the A wave and the B wave. And the recording parameters are called the amplitude and the timing. So we need to know what is the amplitude of each wave and what is the time of the each wave. And what in response to if the light or if the eye is darkly adapted or it is lightly adapted. So let's start what are the different waves of the ERG. So here is the typical ERG pattern. As we initiate the stimulus here, the first wave to appear, it is called the A wave. And the A wave, it is a negative wave that is initiated by the photoreceptors. So the first wave, again, it is called the A wave, and it is a negative wave, which the source of this wave is the photoreceptors. Then this is followed by the B wave. The B wave is the second positive wave, which is a larger one. It is larger in amplitude than the A wave, and its source is the bipolar and molar cells. So the bipolar and molar cells are the response of the B waves. Then in the ascending limb of the B wave, there is a small wavelets like saw teeth. This is called the oscillatory potentials. They are fast wavelets that have higher frequency and smaller amplitude, and they are the source of these wavelets are amacrine cells. Then there sometimes may be another positive wave that could be appear here. This is called the C wave, and it will come from the retinal pigment epithelium, but it is not present all the time. And finally, there may be very rarely to find a wave called a D wave, which is very, very rare in man, but it is more in animal. So again, this is the basic structure of the ERG, with the first negative wave called the A wave, and the second positive wave is the B wave. So this is the most important components of the ERG. So what is the source? Let's remember. From where does the A wave come from? It is from the photoreceptors. The B wave come from the bipolar and molar cells. And the oscillatory potentials come from the amacrine cells. Sometimes the C wave comes from the retinal pigment epithelium, but this is not very common. Again, the A wave, the B wave, A wave from the photoreceptors, the B wave from bipolar and molar, the C wave coming from the retinal pigment epithelium, the oscillatory potentials coming from the amacrine cells. D waves are rarely present in the human. Again, here is the first negative wave, it is the E wave. The second wave, or second positive wave is the B wave. Sometimes we can see the C wave. So in order to judge the ERG, it is normal or abnormal, what are the parameters that we look for? We need first to know what is the amount of the wave. It is large amount or a smaller amount. This can be referred as amplitude. So this is the amplitude, and then we need to know some information regarding the duration of the impulse. So we have two parameters that will express the duration. One is called latency, and the second, it is called the implicit time. So what is the difference between them? The amplitude. For the A wave, in order to judge the A wave amplitude, this be judged from the baseline or the isoelectrical line to the trough of the A wave. Since the A wave is a negative wave, we measure from till the trough, while the B wave is positive. So we measure it from the trough of the A wave to the peak of the B wave. This is very important, that the B wave is not measured from the isoelectrical line. It is measured from the least or the lowest point of the A wave. Sometimes this is asked in the MSQ. So let's see. Amplitude of the A wave, meaning that it is from the isoelectrical line. Let's say that we initiated the stimulus from here, from the isoelectrical line till the trough of the A wave. So this is the amplitude of the A wave. while the amplitude of the B wave, it is not from the isoelectrical line, but from the trough of the A wave until the peak of the B wave. So this is called the amplitude of the B wave. The latency, it is the time interval between the onset of a stimulus and the beginning of the A wave response. So if we are initiating the stimulus from here, and the stimulus or the stimulus or the A wave is started here, so this is called the latency of the A wave. If we initiated the stimulus from here and the B wave started from here, then this is called the latency of the B wave. So normally the latency of the A wave is about 2 milliseconds. The implicit time, it is another form in order to describe the duration of the wave, but it is the time between the onset of light and the maximum response. So the maximum trough of the A wave or the maximum peak of the B wave. So what is the implicit of the A wave? Like here, it is the time from initiation of the stimulus until the peak or the trough of the A wave. Or for the B wave, it is the time from initiation of the stimulus until the peak of the B wave. This is called the latency. So this is the latency of the A wave, and this is the latency, the implicit of the A wave, and this is the implicit of the B wave. So here it is just one word that will make the difference. Latency, it is the difference between the initiation of the light and the onset. Implicit, it is the difference between the initiation of light and the peak, or the onset, or the beginning, or the peak, or the maximum of the wave, either the peak or a trough. For the ERG recording protocols, there are different recording protocols. So you may find different protocols in different books, but they will follow a specific pattern that the patient should be fully dilated in order to stimulate the peripheral retina. The patient should stay in the dark for a while, and then we stimulate the retina in order to isolate the rods. And then the patient will stay in the light for 10 minutes. Then we will stimulate the retina in order to isolate the cones. So the difference here is just what are the different types of lights and that we need to use in order to stimulate or isolate specific photoreceptors. So for example, if the patient stays 30 minutes in the dark, then in order to isolate the red response, we can use a scotopic blue or a blue light that will cause maximum stimulation for the rods, or we can use a dim white light, because if it is a bright light, this will cause stimulation to the cones. Then we can we need to know what is the maximum response. Maximum response meaning that we are now making the retina work by its full capacity. So we are stimulating the whole rods and the whole cones. This can be done by stimulating as the patient is in dark adaptation. So we can now use a scotopic white light, so a white light present in a dark adapted eye, or we can use a red light. The red light also can stimulate the cones since it has a long photoreceptors, and the cones will not or the rods will not respond to a red light. Then we measure the oscillatory potentials, and after the patient is in the light adaptation, now all rods are bleached so that we are now canceled the effect of rods. And by doing a single flash cone response or photopic white flash or even a red light, again, this can stimulate the cones. Then by using a 30 Hertz flickering or intermittent stimulus, this again can be used to isolate the cone's response. So red light can be used for dark or for light adapted eye in order to isolate the cones, whether in a dark adapted eye or in a light adapted eye. So let's start first by dark adaptation. The first thing that we need to record is the rod response. So for the rod response, we just use the patient stays 30 minutes in the dark, and now we use a white light, dim white light, or blue light that will cause stimulation to the rods. This will lead to a response like a dome shaped, with initial A wave, sometimes cannot be seen or hidden, and larger B wave. It has a longer implicit time because only rods contribute, so there is no cones. That's why it needs some longer time in order to reach its peak. So again, rod response, it is the first wave response of the ERG that will be initiated, or that will be initiated by the rods in a dark adapted eye using a white light or a blue light. For the maximum combined response, we need to make the retina work by its full capacity. So we need to make the retina respond to by both cones and rods. And this can be done by very bright white flash or by red light. And in this condition, you will find that there is a negative deep A wave, and there will be a tall B wave with longer implicit time and larger amplitude, because here the larger amplitude is due to maximum response of both rods and cones. The ERG recording of the oscillatory potentials, and then we can change the parameters of the device in order to record these oscillatory waves. These are called oscillatory potentials, which have a low amplitude and have higher frequency, so that by using bright flashlight and changing the recording parameters, we can detect these oscillatory potentials. Then the patient stay for 10 minutes in the light in order to bleach the cones and suppress the function, bleach the rods and suppress the function of rods. And then we need to isolate the functions of cones. So first of all, we use a single bright flash, and this will cause only stimulation of the cones because the rods are not functioning now, because they are already suppressed by the light adaptation. Since the cones are very few, as I told you, it is 5 million to 6 millions compared to the 120 millions of the rods, so the electrical response coming from the cones will be weak or will be small. This will result in smaller E wave and smaller B waves, with the waveform more peaked with shorter implicit time and smaller amplitude, because this is only attributed to the cone function. Sometimes this single flash cone response can be done by bright white flash or by even red light. So the red light will again stimulate the cone functions. Then the flickering response. In order to stimulate the cones, we can present a flickering light, an intermittent light that will intermit or will have the frequency of 30 Hertz. If we present an intermittent light with this frequency, this will lead to response that's coming only from the cones, as the rods cannot respond to this frequency or to this higher frequency. So this will lead to multiple small waveforms that are referred to the flicker response. If the flicker response is poor, then this means that the cones are not functioning well. As we said, this is the difference between the intermittent, and as we increase the flicker into 30 Hertz, this will cause a response of the cones, because if we increase the critical fusion frequency of the rods are less few, so that the rods cannot respond to this 30 Hertz as it will see it as a continuous. So one of the common questions in this topic, how to isolate the functions of the rods and the cones. In order to see to isolate the functions of the rods, the eye should be dark adapted. We use a short wavelength light like the blue light, or we use a low intensity light, a dim light. In order to stimulate or to isolate the functions of the cones, the eye should be light adapted, and using a longer wavelength like the red, or we use a high intensity light, or we use a flicker light of 30 Hertz. So this is not required from you to know what are the different patterns, but I will just bring these photos for illustration in order to understand what does it look like. In retinitis pigmentosa, this is one of the commonest diseases that we use the ERG in order to diagnose, because it can diagnose the retinitis pigmentosa even with no apparent fundus lesions. But in this condition, with advanced retinitis pigmentosa, there will be the defect not only for the rods but also for the cones. So if there is a normal eye response, you can see this is the scotopic response using the blue light and the red light, and this is the A wave and B wave. And then with the scotopic light, this is the A wave and B wave, the flicker response, the 30 hertz flicker response, and the photopic white showing the normal A waves and the B waves. But in retinitis pigmentosa, there is absence of the normal pattern, as you can see here, and that will affect both the rods in the dark and the cones in the light. So the retinitis pigmentosa will cause affection of the rods first. In this case, affection of the rods and the cones, meaning that it is at an advanced stage. The central retinal artery occlusion will affect the, you can see that there is affection here, so there is absence of the normal pattern. But what I wanted to illustrate here is that the A wave here, normally the A wave is smaller than the B wave. Look, this is the B wave, and this is only the A wave. This is the A wave, and this is the B wave. So this is the normal. But in case of the central retinal artery and other vascular diseases, there will be what's called a negative response. A negative response meaning that the B wave is smaller than the A wave. So the A wave is larger than the B wave. The negative wave is larger than the positive wave. This occurs in the disturbance of circulation like giant cell arteritis, like central retinal artery occlusion, and other atherosclerosis and other vascular diseases. This will cause reversal of the pattern and also loss of response due to death of the photoreceptors or death of the retinal layers. So there is no response of the bipolar or the motor or whatever. Here, let's see what are some diseases that may affect only specific category of photoreceptors. For example, a disease called cone dystrophy. Although the fundus appears relatively normal, but you can see that in scotopic or in the dark, there is some response. Maybe not normal, but there is some response. So the scotopic here shows some response. In comparison to the photopic or the white response or the light response in the lightly adapted eye, there is absent response. So there is no flicker at all here. There is no photopic white light. It is just a straight line. So this means that the cones are affected more severely than the rods. The reverse occurs here. This is a disease called the congenital stationary night blindness. So you can see that this is the normal, and this is the electrophysiological recording of the congenital stationary night blindness. Check here for the scotopic. As we stimulate only the rods, it is a flat line. But when you are using a scotopic white, we are using a bright light white in order to stimulate some cones. There is starting some response to appear. If we are using the flicker and photopic white, there is a response that is more or less close to the normal. So the cones here are functioning well, but the problem here with the rods. That's why the patient will complain from night vision. So after discussing this example, I guess that you now understand what is the value and what is the importance of interpretation of the ERG. So what are the different types of ERG? We have different types according to the stimulus zone. So we can stimulate the whole retina. This is called the full field ERG, or we can stimulate only the macula. That is called the focal ERG, or we can stimulate the ganglion cell layer, or this is called the multifocal ERG. So the multifocal ERG is just as a recording not from all retinal layers, but it is from the ganglion cell layer and the retinal nerve fiber layer. So it will reflect the function of the ganglion cell layer and the retinal nerve fiber layer. Depending upon the stimulus, we can present a single flash ERG or a red flash or a blue flash or a blue filter in order to isolate the rods or cones. Pattern ERG is a specific type of ERG also used to isolate the function of the ganglion cell layer and the retinal nerve fiber layer. This is just by changing the type of stimulus and changing the recording parameters from the device. According to the state of retinal adaptation, we have the scotopic ERG. As we said, we have the mesopic, in which the patient, we record the ERG under moderately illuminated conditions, and the photopic ERG, in which the retina is intensely exposed to bright illumination. Factors affecting the ERG response will be, first of all, is the stimulus. So if we increase the intensity of the stimulus, this will increase the intensity or the amplitude of the ERG response, and the implicit time will be shortened. So the time from starting the stimulus to the maximum peak or the maximum response of the wave will be shortened. And also the stimulus will control the response or control the photoreceptor affected or stimulated if it is continuous or stimulus or it's flickering. So if it is flickering with a 30 hertz, as we said, then the ERG will represent the cones only, because the rods cannot respond to this higher frequency. Their critical fusion frequency is much lower, so they will see this flickering light as continuous rather than intermittent, because the rods have critical fusion frequency that doesn't exceed 20 to 21. So what happens if we increase about this 30 hertz? If we present an intermittent light of about 100 hertz, then the ERG will lose its characteristic waveform. So it will not present a waveform like this, but it will present a continuous line. Why? Because now even the cones cannot see this intermittent stimuli, but can see it as a continuous line as the critical fusion frequency is reached. The second thing is the adaptation. As we said, if the dark adaptation will cause a stimulation or favor the dark adaptation will favor the response of the rods, while the light adaptation will favor the response of the cones. Also, the kind of light that will stimulate the retina will change the nature of photoreceptor stimulated. So the rods will respond better to the blue light under dark condition, while the cones will respond better to the red light under the photopic conditions. Age and sex also have some rules regarding the responses. So the smaller ERG can be elicited even within hours from the birth, and the baby will reach the adult form of the responses of ERG at the age of 2 years. In the adult life, the size of the ERG will gradually decline as we get older. There will be decreasing of the electrical activity within the retina, and usually the ERG size is more larger in women than the men. Let's now see what are the abnormal ERG responses. The ERG can be supernormal, or the amplitude can be much above the normal limit. This can occur due to early siderosis bulbi, in which there is iron material or iron foreign body inside the eye. For example, this iron will cause hyperexcitability of the retina in the early stages, leading to hyperresponse. Also, albinism, since that there is no pigment or no melanin in the retinal pigment epithelium, this will cause a scattering of light inside the eye at a much higher frequency than normal, leading to much more stimulation to the retina and much more resultant ERG response. Subnormal response occurs or decreasing the amplitude of the retina. This occurs due to if there is large area of the retina which is not functioning well. This is like the examples that I showed you in case of retinitis pigmentosa, in chloroquine and quinine toxicity, which are antimalarials, retinal detachment, some systemic diseases like vitamin A deficiency, hypothyroidism, and mucopolysaccharidosis, and anemia. Extinguished response meaning that there is a complete absence of the response. There is a destruction, total destruction of the retina. And this can be seen in cases of advanced cases of retinitis pigmentosa, as I showed you, or if there is complete retinal detachment, so the retina is totally not functioning. Advanced siderosis bulbi, so the siderosis bulbi causing hyperexcitability and hyper response in the start, but with further toxicity of the retina, this will cause a complete absence of the response. Choroideremia, which is one of the degenerative choroidal diseases, and the Leber congenital amaurosis. In the Leber congenital amaurosis, the ERG is diagnostic. Negative response, as I showed you, this means that there is a large A wave. So it should be a smaller A wave than the B wave, but in this condition, it is larger A wave, which means that there is abnormality in the retinal circulation, as in atherosclerosis, giant cell arteritis, central retinal artery occlusion, and vein occlusion. Finally, some oscillatory potential abnormalities, which occurs due to either can disappear at all, as in diabetic retinopathy, ischemic retina disorders, and central retinal artery occlusion, or some changes occurs in retinitis pigmentosa and Behçet disease and siderosis bulbi, and rapid decline. Rapid decline in the amplitude can occur due to ischemia. So it was postulated that the oscillatory potentials changes occurs due to ischemia, as in diabetic retinopathy. So with increasing the ischemia from diabetes, as in changing from non-proliferative to proliferative diabetic retinopathy, this will result in decrease the response coming from the amacrine cells and decrease in the amplitude of oscillatory potentials. So does this mean that we can use ERG for all patients? The answer is no, because the ERG have some limitations. First of all, in the ERG to be expressive, or in order to be indicative for the disease, this disease should be diffuse, as the ERG will record the electrical response from the whole retina. And so if there is a localized lesion, like a macular hole, or like a localized macular hemorrhage, or a localized chorioretinitis, this will not result in gross or diffuse change in the electrical potential coming from the retina, so that the ERG amplitude may not be detectable. So the ERG is not always can be used for the all retinal lesions, but these lesions should be diffuse. The second thing that the ERG used to detect the abnormalities in the outer retina, like up to the bipolar cells. So if there is abnormalities involving the ganglion cells and the higher visual pathway as optic atrophy, it will not able to detect it unless for the ganglion cell, unless the multifocal ERG and the pattern ERG. These ones will be able to detect the ganglion cell abnormalities, but for the higher visual pathway, there will be the ERG will have no role. So it is nonsense for a patient who has a compressive lesion at the optic tract, for example, and to order for him ERG, although he has an optic atrophy, but this will not reflect in the ERG, as ERG will only reflect the abnormalities in the retinal function. Also, the ERG response will represent the mass activity of rods and the cones. So you will know that totally the rods are not functioning, or totally the cones are not functioning, but they cannot be used for diagnosis at all times. So this cannot be used as an alternative to clinical diagnosis. So in clinical diagnosis, you need to combine the clinical picture with the resultant electrophysiological study. But electrophysiological study per se is not used for diagnosis. As I showed you, you may have some abnormalities in the rods function. This can be congenital stationary eye blindness, could be retinitis pigmentosa, could be wide variety of retinal disease. The second electrophysiological study here is called the electroociogram. So the electroociogram, it is a measure of the resting potential of the eye. So The resting potential is the difference between the difference in the voltage between the cornea and the outer retina. So this device is just basically record the difference in electrical potential between the cornea and the outer retina, specifically at the retinal pigment epithelium. This is done by placing electrode at the inner and outer canthus and asking the patient to move his eyes rapidly between them. So he moves his eyes right and left, right and left, right and left, medial and lateral for a specific distance. And then these electrodes will record the electrical potential between the cornea and the outer retina. This can be done in the dark adaptation and in the light adaptation. So the patient first stay in the dark for about 20 minutes. This is followed by light adaptation for a shorter time. Then what happens after this? Then the device will calculate the maximum response in the dark, which is called the dark trough. And then there will be, so that the electrical potential will fall to the maximum extent during the dark. And then the electrical potential will increase to the maximum during light, which is called the light peak. So this device will give rise to a ratio, or the recording parameter here is the ratio between the light peak to the dark trough. This is called the Arden ratio. So the Arden ratio it is an expression of the ratio between the electrical potential during the maximum light and the maximum electrical potential during light to the maximum electrical decline during the trough or during the dark. The normal response for the Arden ratio to be 1.8 or much greater. If it is less than 1.65, then this is considered abnormal. So again, the Arden ratio, it is the difference or the ratio between the light peak to the dark trough multiplied by 100. Normally it's more than 180, less than 180 or till 165. This is a borderline. Less than 165, this is subnormal. Even if it is more than 10% between both eyes is considered significant, and the patient should be cooperative enough, because in this test we need the patient to move his eyes right to left. One of the important questions in the MCQ is the location of EOG response. So the electrooclogram response is coming from the retinal pigment epithelium. So if they have disease affecting the retinal pigment epithelium, this will result in an affection of the EOG. Also, if the retinal pigment epithelium and there is no contact between the RPE and the photoreceptors, again the EOG is abnormal. For example, if there is retinal detachment and the neurosensory retina is separated from the RPE. So although the RPE is normal, but there is no normal communication between the RPE and photoreceptors in order for the electrical impulse to reach the electrode and to be recorded. So no physical contact between the RPE and photoreceptors is mandatory for this response to be normal. Here is an example for the electrooclogram record. So this is the pre-electrical activity, and at the dark there will be decline in the electrical activity, and in the light there will be increasing in the electrical activity. So in the right eye, the Arden ratio was about 1.5, which is considered abnormal. In the left eye, the Arden ratio was about 1.76, which is considered almost normal. One of the most important clinical indications for ordering the EOG is the best vitelliform macular dystrophy, in which there is appearance of egg yolk appearance, or one of its stages is called the egg yolk pattern or egg yolk appearance, and due to deposition of lipofuscin pigment within the retinal pigment epithelium. The value of this test is that it can differentiate between the best vitelliform macular dystrophy and the pseudo vitelliform macular dystrophy, and not only that, but it can also detect the carrier state. These patients who have no clinically visible fundus lesion, but their EOG will be abnormal. So remember, the EOG is the disease of the egg, which is the best vitelliform macular dystrophy. But in other diseases, sometimes the EOG usually doesn't add more information than the ERG, except for some diseases like the chloroquine toxicity and the siderosis bulbi. So in such conditions, EOG can sometimes show some abnormalities even with the presence of normal ERG. The limitations of EOG is the same like the ERG. So EOG can show is recording of the diffuse response from the retinal pigment epithelium. So if there is isolated disease affecting the sensor retina or the RPE, will not affect the EOG. And the second thing that EOG is normal in diseases that involve the ganglion cells and the higher visual pathway as optic atrophy. Finally, we have what's called the visual evoked potential. So what is the visual evoked potential? All the previous mentioned electrophysiological studies measure the electrical potential in the retina, but nothing outside the retina. The first device, or the first and the only device that will record the electrical activity from the visual pathway, it's called the visual evoked potential. And in this device, this will record the visual activity coming from the eye until the visual cortex passing through the visual pathway. So this is the only test or that can be used clinically in order to test the state of the visual system beyond the ganglion cells. Types of the VEP. We have two types of the VEP. We have what's called the flash VEP and the pattern VEP. In the flash VEP, we are presenting a flash stimulus of different luminosity and ask the patient, or the patient just open his eyes and look at it, and we record the electrical potential from his brain. So that's why it can be useful for children who cannot fix for a long time and uncooperative individuals. And one of the main advantages of it that it is not affected by the media opacity, as we are not testing the appreciation of a stimulus, but we are testing we test if the stimulus is perceived or not. The pattern VEP is by presenting a pattern in front of the patient. This pattern is usually a checkboard. So checkboard having alternating black and white circles. This pattern can either go on and off. So this is appearance and disappearance, the check pattern, or even what's called reversal. So the black and white circles switch. So the black become white and the white become black. This is called reversal pattern. And also the pattern have some of its values that we will discuss now. So here is a patient who is checking a pattern VEP on reversal pattern. So the alternating dark and white circles are present in front of the patient's eye, and the electrical potentials are recorded that will represent the function from the ganglion cell layer till the visual cortex. The patient's pupil here will be undilated, sitting 1 meter in front of the monitor, with the electrode present at the midline, at the forehead, the vertex, and the occipital lobe. We then present checker sizes in front of him, and then the recording is done. As we said, the normal VEP and normal ERG and normal EOG, we need to know what is the normal VEP. The normal VEP or the normal waveform in the pattern VEP has 3 main waves. Initial negative wave that is called N1, followed by a positive wave that is called P1, followed by a third negative wave that is called the N2. So what is recorded mainly is, again, it is the amplitude and latency. The latency of the N1 from the initiation of the stimulus till it appears about 70 milliseconds. The P1 will appear at the 100 milliseconds, while the N2 start to appear at 135 milliseconds. So if these waves appear later than this, then this means that these waves or this patient has delayed latency. The flash VP is more complex than the pattern, present with 2 positive waves and 2 negative waves. So here is the the appearance of normal pattern VEP. The first wave, it's called the negative wave. The first negative wave is called N1, which appear at 75 milliseconds, so it's called N75. The second one, it's a positive wave, which appears at 100 milliseconds, so it's called P100. Then the third one, it is a negative wave that is starts to appear at 135 milliseconds, so it's called N135. So P for positive, N for negative. Here is the flash VP recording, show 4 waves, N1, P1, N2, P2. So what are the parameters that we interpret in the VP? The VP is interpreted in the terms of amplitude and latency. Amplitude and latency. So latency usually to peak of the first positive wave or the P100. Usually this is the most significant wave, which is called the P100 or the first positive wave. So we need to know what are the parameters that we need to check for in different conditions. So if the patient problem is a visual acuity, so if we are concerned about the patient's ability to see, or there is a lesion that will cause decrease the patient visual acuity, so the amplitude here is the most concerning parameter. But if there is a lesion of the pathway is suspected, like for example, there is inflammation of the optic nerve or optic neuritis, then the latency here is measured. So there is this inflammation will cause delayed conduction of the nerve. So this will result in delayed appearance of these waves. So for example, here is a patient, this is a normal patient, and you can see this is the N1, P1, N2, P2, and this is a flash ERG. And check this ERG or VEP for patient with optic neuritis or multiple sclerosis. You can see that the N1, P1, N2, P2 show appears later than the normal. So there is increase in the latency of different waves. This means that there is a delayed conduction, and this can be diagnostic for the optic neuritis. So what are the different indications? As we said, in the optic neuritis, there will be both reduced amplitude and increased latency. But the difference here, or the main issue here, is that the reduced amplitude will return to normal after resolution of the optic neuritis. But the decreased amplitude or the delayed latency will never return to normal even after the acute attack. So even after the acute attack, the patient return, his vision return normal, there will be the amplitude will return normal, since the patient has normal vision. But if there is the amplitude, then but if after resolving the attack, then this patient will still have decreased latency or delayed latency. Compressive optic lesions also. Just hold on. The compressive optic nerve lesions also can affect the VP, but usually it is just decreasing the amplitude with no affection of the latency. Visual acuity also can be used in both in infants or mentally retarded. Can be used also as an indicator. The VEP can be used as an indication for the visual acuity. So it can be just by presenting checkerboard and decreasing the size and increasing the size of these checkerboards. This can be an estimation. If the patient can see, this will result in a specific kind of stimuli. This will mean that the patient can see. And the same thing with the VEP. The pattern VEP, the same thing can occur with the malingering. The pattern VEP amplitude and latency can be changed by the by fixation, but there will be a response. So that this will be resulting in Just hold on. Someone is snagging and calling me, keep calling me and not stop. Okay. Then assessment of the visual potential in patient with opaque media. As opaque media, I told you that the pattern here is of no value, but the flash VEP is of a great value because we just increase the brightness of the stimulus, and then the patient can be able to record some electrical impulse. Unexplained visual loss as well. So in unexplained visual loss, if the VP is useful for, so if for example, if the patient has some orbital lesion or orbital hemorrhage or compressive lesion that you suspect that can cause some compression to the optic nerve, you may be able to detect that there is affection of the visual pathway, or even if there is a patient with normal fundus and you are suspecting that there is a lesion of the photoreceptor, then there is a lesion affecting the ganglion cell layer. So VEP can be of some good value. Amblyopia also is important, and in such condition, the flash VEP is normal, but the pattern VEP can show decrease in the amplitude with relative sparing of the latency. So in this, the amblyopia patient will have a normal flash VEP, but abnormal pattern VEP. And this abnormal pattern is due to decreased amplitude, not latency. As latency here is normal, his visual pathway the conduction is normal. But since there is a decreasing or there is a suppression of the stimulation or suppression of electrical stimulation in the brain, this will result in decreasing the amplitude only. Glaucoma also can be, the VP is not only, it is not routinely asked in the glaucoma, but it can be useful for detection of central defects, and in case of refraction also can be done, especially for children. So in the children, we can present some in the pattern VEP can present stimuli of increasing or decreasing the size. So by increasing or decreasing the checkerboard, then if they produce an image over the retina, this will result in a response. And if they are not present in the retina due to presence of refraction error, then this will not cause the same response. Dr. Sam asked is about the acuity is only detected with the pattern VP. Yes, so the pattern is just a rough detection or a rough estimation of the patient visual acuity. So we can't rely on it. We can't rely on it to have an accurate measurement, but sometimes this is the only thing that we can have in our hands. So I guess that this is the end of our lecture. This is, do you know what is this bird? What is this bird is called? Actually, this bird is called the flicker bird. So what is he doing in this tree? This is called just flickering. So flickering is an intermittent stimulus. Intermittent knocking this tree is a flickering. So this is just to remind you of what is a flicker. Thank you very much. So this is the end of our first lecture. We'll take a break about 15 minutes and we'll be back with the second lecture.